we do in the select cases to rule out distant metastasis. So, like I said, Mercury study was done in 2002-2003, where it has clearly said that MRI is useful in identifying the local recurrence and overall survival. So the key role of MRI, like I said, it is whether it is a T3 or T4 disease, evaluation of the circumferential resection margin, and the tumor involvement of the levator ani muscle, EMVL, lymph nodal and perinodal involvement, the peritoneal involvement, which we will all see in the next coming slides. So MRI technique. The T1 and T2 weighted sequences are recommended both for both primary and restaging, and only T2 weighted non-fat suppressed sequences are recommended. So this, if at all, if you are practicing, if you are working in any institution setup, please keep a note of this one, that only T2 weighted images and T1 and T2 weighted non-fat suppressed. This is most important. Many sequences which we see, which we get the scans from outside, they do a fat suppressed sequence where the mesorectal fat is suppressed and will not be able to assess the extent of extramural extension. And post-contrast sequences are not useful. Normally, the routine requisition which comes is MRI with contrast or CT with contrast. So contrast is not required. So non-contrast, non-fat suppressed sequences and T2 weighted, where there is a large FOV sequence which is like a magnified image. So small FOV, that means magnified images that are useful for assessing the local extent of the tumor. And the technique which I want mentioning, so this is the rectal tumor, and this is the sagittal view of the pelvis, and the orientation of the axial view should be taken in perpendicular to the rectum rather than the perpendicular to the body. So normally the true axial scans are true. This is the perpendicular to the rectum tumor rather than the perpendicular to the body. So this is how we see it on the axial. So this is called oblique axial view, and this is a small FOV oblique sagittal view. So the sagittal view is used for planning the MRI, and the axial views are taken perpendicular to the tumor rather than the perpendicular to the body. So if at all, if we take a perpendicular to that body, then that might give a spurious involvement of the mesorectal fascia or adjacent structure. I hope the images are projecting well. So this is how the MRI is acquired on axial view. So this is the MRI, this is the tumor which we are seeing it on the axial view, and this is the sagittal. And now we'll go to the MRI anatomy of the rectum, and we'll see where the tumor is located, how to identify the depth of invasion, mesorectal fascia, what is mesorectal fascia, how to identify MRF, mesorectal fat and nodes, and the rectal layers, submucosa, muscularis propria, levator ani, and anterior petrol reflection and invasion of adjacent organs. So this is a high resolution MRI. This we routinely will not be able to see, but if at all, these are the normal layers of the rectum. This is the muscularis, this is the mucosa. This is the normal mucosa of the rectum, which appears as a dark hypointense line, and the submucosa appears bright, and the muscularis propria is the dark hypointense line. So if you remember this dark hypointense line, then that would be helpful for you. The tumor is normally intermediate in signal, that is in between the bright and the dark. So if at all, if there is any tumor, this will be intermediate in signal, which will be breaching the muscularis and the submucosa. And if the tumor extends beyond the muscularis propria, that will be T3. And if it is invading the submucosa and the muscularis, then that will be T2. And if it is involving only the mucosa, submucosa, that will be T1 or T2. So rectum is divided into three parts based on the distance from the anal verge. The lower rectum is lower 5 centimeters, mid rectum is 5 to 10 centimeters, and upper rectum is 10 to 15 centimeters. And the rectosigmoid junction has a variable location from the sacral promontory. So the rectosigmoid junction is identified where on the axial view where the sigmoid takes off. That is, the rectum is a vertical tube, and when the rectum becomes horizontal, then that is place where we call it as the rectosigmoid junction. So this is the normal MR anatomy. This is the lower rectum, this is the mid rectum, and this is the upper rectum. And the MRI will not be able to identify the anal canal proper and the rectum, where the dentate line will not be able to be seen on the MRI. So the lower rectum is considered as 5 centimeters of tube, and the rectum below the anorectal junction, that is below the puborectal listings in the proper anal canal. And this is the sigmoid takeoff, where the rectum comes vertically, and then when it becomes horizontal, that is the rectosigmoid junction on an axial view. And this is a femoral vesicle, this is the rectum, and the surrounding bright intense is the fat, which is hyperintense, that is the fat, that is the mesorectal fat, and the black line, which is enclosing this mesorectal fat with the rectum, is the mesorectal fascia. So what is mesorectum? So as you know, the advances in the surgery, TME has revolutionized rectal surgery. After the TME, after the advent of TME, the local recurrence rates have come down to less than 10%. And with TME and with CTRT, the local recurrence rates have further come down to less than 2.4%. So total mesorectal excision is the norm, where the surgery is removed. Surgery removes the total rectum in toto along with the mesorectal fat, and the plane of surgery goes through the mesorectal fascia. That is total mesorectal excision. And for a TME surgery, the distance that the tumor should be away from the mesorectal fascia, at least more than 1 millimeter distance should be there for a TME to have a free margin. For this, MRI has to accurately depict that the margins are free. So you should know where the MRI is. So MRF encloses the mesorectum is enclosed by the mesorectal fascia, which forms the natural boundary of the tumor and through which the surgical planes go. And if the mesorectal fascia is involved, then the extent of surgery will be beyond TME. So the mesorectum contains the rectum, fat, lymph nodes, and the draining vessels. So like I said, the TME, the circumferential extent of the tumor into surrounding mesorectum is strongly associated with local recurrence than the longitudinal tumor. So if the MRI says the mesorectal fascia is involved, then the local recurrence rates are higher. And if the tumor is free of the circumferential distal margin, then the recurrence is lower. So enlarged excision of the mesorectum has less likelihood of cell spillage and residual tumor recurrence. So, and it also has a preserved genitourinary function. So the rectum is enclosed by the mesorectal fascia only in the lower, mid, and lower part of the rectum. So this blue line is the mesorectal fascia. So if you see, rectum is a non-peritoneal structure. So in the upper rectum is covered by the peritoneum. So along the anterior and the lateral aspect of the upper rectum is peritonealized, and the lower rectum, the blue line, is the mesorectal fascia, which is non-peritonealized. So there is no serosa in the lower rectum. So if you see the rectum, the lower rectum there is no serosa, and it is covered by the mesorectum and the mesorectal fascia. So the lower rectum, mid rectum, and the upper rectum along the posterior aspect is covered by the mesorectal fascia. So if you see, this is in the coronal. This is the mesorectal fascia is covering the rectum along the lateral aspect and the posterior aspect. So if you see in axial, along the posterior aspect, this is the peritoneal reflection, and again this is in the mid rectum. This is the peritoneal reflection. So anteriorly, this is the mesorectal fascia, and lower down, this is completely surrounded by the mesorectum. So normally in the males, above the level of seminal vesicles, or in females up to the level of cervix or lower part of the uterine body, the peritoneal reflection comes. So anteriorly, the peritoneal reflection involvement would which upstage the tumor to a T4A, and inferiorly it will be T3. So this is the MR image of the same. This is the rectum, and this is surrounded by the mesorectal fat, which is bright, and the black line which you can see, that is the mesorectal fascia. So this is mesorectal fascia, the fascia enveloping the mesorectum. It is completely surrounding the rectum at the level of the seminal vesicle. So these hyperintense grape-like structures anterior to the rectum and posterior to the bladder and prostate. So this is the superior aspect of the prostate, that is seminal vesicle. This is the prostate and this is the bladder. So the bright structure, the bright thing, what we are seeing, that is the fat. So as you can see, the subcutaneous fat is bright and the fat surrounding the rectum is also bright, and the line, the black line, the fascia is the black line. So this is the TME plane. If the tumor is away from the TME plane, you can do a TME total mesorectal excision. So this same thing on the coronal view, this is the mesorectal fascia, which comes down and thins down and fuses at the levator ranae. So this is the levator ranae muscle. This is the external sphincter. This is the rectum, and the circular muscularis propria of the rectum continues down as the internal sphincter, which I will talk to you, which I will explain to you later. But now you should understand the concept of mesorectum, how to identify the mesorectal fascia. So you can see this is a very thin black hypointense line. That is the mesorectal fascia. Then this is the extra mesorectal plane, and this is the mesorectal plane. So this is the mesorectal fat, this is the mesorectal fascia, and this is the levator. So the mesorectal fascia comes and thins down and fuses at the level of levator ranae. So this is the, I'll show you the, this is the upper rectum. This is taking the turn. That is so that is where the rectum taking the turn. That is the rectosigmoid. And now you can see this is the intermediate signal intensity tumor. If you can appreciate, this black hypointense line is the muscularis propria of the rectum, and the tumor is intermediate to this one. So it is hypo compared to the adjacent fat and brighter as compared to the adjacent muscle. So that is why we call it as intermediate gray to the black and white. So this is the intermediate intensity tumor, which is involving the muscularis line, and this is the mesorectal fat. And posteriorly, you can see this black line, that is the mesorectal fascia. So posteriorly, it merges with the presacral fascia, and posterior to the mesorectal fascia is the presacral fat. So mesorectal fascia is in the posterior and lateral aspect in the upper parts, like I said. So anteriorly, what you are saying, this is not mesorectal fascia, but this is the peritoneal reflection. So if you see, it might look like a continuous line, but on a sagittal line, you will see a separate peritoneal reflection. So laterally and posteriorly, you will have mesorectal fascia. If you see, this is a circumferential tumor which has gone beyond the muscularis propria and reaching up to the mesorectal fascia posteriorly. So posterior MRF is positive in this case. So this is the tumor. This is the mesorectal fascia. This is the urinary bladder, and the seminal vesicles are just coming. So these are the seminal vesicles. So from this level, you will see the mesorectal fascia in completely enveloping the mesorectal fat. So this is the mesorectal fat, and this is the extra mesorectal fat. This is the bladder. So this is the lower, below this one. This is again thinning down, and then this is the levators which are seen. Prostate, seminal vesicle, mesorectal fascia, and then this turn, and then below this is the external sphincters, and then the space between those two will be the intersphincteric space. So the mesorectal fascia ends at the level of puborectalis tension, and then there will be a thin 1 mm thin fat between the internal and the external sphincter. This is the internal sphincter and this is the external sphincter, and the plane between those two is the intersphincteric space. So this is the ischiorectal fat. This is outside the rectum. So this is the ischiorectal fat, prostate, sphincters. This is the puborectalis, pubococcygeus, puborectalis, and the external sphincter. So this is a sagittal view of the same. So you can see this is the peritoneal reflection. As you can see, the peritoneal reflection comes down and reflects over the lower part of the seminal vesicles. This is the peritoneal reflection. And this will be the mesorectal fat, which goes with the retroprostatic or the denomulus fascia. And posteriorly, this is the mesorectal fascia. And posterior to this, it's slightly brighter than the mesorectal fat. That is the presacral fat. So this is the sacrum. Anterior to the sacrum is the presacral fat through which the nerves and vessels run. And anterior to this is the presacral fascia, which is not seen separately on MRI. That fuses with the posterior mesorectal fascia. So this black line is what you have to trace. So instead of remembering presacral fascia, all these things, just you have to write black line, which is posteriorly seen, that is the mesorectal fascia, and if it is involved, then you have to go beyond it. So if there is the involvement of the posterior mesorectal fascia, the extent of the surgical plane would go beyond this one. So always you want to see that the tumor, the surgical plane goes beyond the tumor. So this is the tumor. So this is the longitudinal extent of the tumor. This is the peritoneal reflection, and this will be the mesorectal fascia. So if the plane, now anteriorly you see there is a very clear-cut plane between the seminal vesicle and the prostate. So this is the mesorectal fascia involvement along the posterior aspect. So like I said, this is the anterior peritoneal reflection. This is the seminal vesicle, prostate, and this is the tumor. This is the rectum. So this is anterior peritoneal reflection. So why I am saying this is because anterior peritoneal reflection involvement upstages the tumor to T4A, and the extent of surgery would be different as compared to the TME and the mesorectal fascia involvement. So this is the tumor. Again, one more example of where this is a mesorectal fascia, and this is the peritoneal reflection. So this is at a higher level. You can see this is a thin line, and you always would not be able to see the peritoneal reflection, but either in a sagittal or a axial plane you might see. And this is involvement of the anterior peritoneal reflection above at the level of bladder. So this is the seminal vesicle. This is at the level of bladder. So again, for your I'm repeating. This is the bladder, seminal vesicle, prostate, and this is the tumor and the rectum. And posteriorly and laterally, this is the mesorectal fascia. So the muscles lying within the pelvis. So we are further going into the anatomy and the lateral pelvic wall. So we see lots of extended, advanced cases in TMH where the extent of resection is always not TME. It's always beyond TME, either involvement of the adjacent muscles or anteriorly involvement of the posterior seminal vesicle. So knowing the anatomy of the relevant anatomy of the pelvis is also very important. So the piriformis obturator, internus, coccygeus, and levator. These are the muscles which we normally see. So like I said, the sphincters are formed by the levator, puborectalis, and the external sphincter. So this is the rectum. The circular muscle layer of the rectum, or the muscularis propria of the rectum, continues down as the internal sphincter. So this red line is the puborectalis junction. So below this, the rectum will become anal canal. So this is this is where the sphincters start. So the mesorectal fascia comes and fuses the levator and ends at the level of the puborectalis junction. And the rectal muscle, the wall of the rectum, continues down as the internal sphincter. And this is the external sphincter. This is the horizontal part is the levator ani, and this is the external sphincter, which becomes thickened at the anal verge. So this is the anal canal, this is the internal sphincter, and this is the intersphincteric space. You can see this thin 1 mm fat. So why we have to see this intersphincteric space and the internal sphincter? Because if the tumor is not involving the ISS, then you can attempt a intersphincteric resection. So if the tumor is above 2 centimeters or 1 centimeter from anal verge, and it is not extending into this space where this is 1 millimeter space. So then you can preserve the external sphincter to an intersphincteric resection. So for surgical planning and with the advances of surgery, the chances of preserving the sphincters is highly possible if we are definite that the intersphincteric space is not involved. So it's easy to do APR, but for the patient, it is a lifelong struggle. So if at all, if you can save, you should save the sphincter. So this is the pectineus muscle. This is the obturator internus muscle. Yeah, this is the obturator internus muscle. This, you can see this black line. And the posteriorly, this line, this is the piriformis muscle. So if the disease is extending posteriorly, then the piriformis is very important because the sciatic nerve travels in front of the piriformis muscle. So if the piriformis muscle is involved, then the chances that the sciatic nerve roots or sacral nerve roots involvement is high. So this is the obturator internus, piriformis muscle. This is obturator externus and pectineus muscle. Again, this is prostate, rectum. So if you can remember obturator internus and piriformis muscle, that should be sufficient. So this is the parts of the sphincters. So sphincters are formed by the pubococcygis and puborectalis muscle. So this is obturator internus muscle which goes outside, and this is the sphincter which goes and anteriorly fuses to the pubis. So this is the urethra, this is the vagina, and this is the rectum. So pubococcygis, puborectalis. So even if we normally do not separately see these muscles separately, we just call them as sphincters, but these are the parts of the sphincter. So this is the levator ani on the sagittal section. Normally, everybody is used to seeing the levator ani on the coronal, where it comes down and fuses and becomes with the external sphincter. So posteriorly also, if there is a tumor sitting on the posterior margin, the chances of involving the levator plate is also high. So the levator ani inserts into the levator plate is the tip of the coccyx. So this also you have to see the posterior aspect whether the levator involvement is there or not. So tumor might be at the puborectalis section or just above the sphincters, where the sphincters might be free, ISS might be free, but posteriorly it might be just touching the or close to the levator plate, and which might give you a positive margin. So you have to look at all the sections before coming to the conclusion that the sphincters are not involved. So again, the same one, piriformis, coccyx. This is the coccygis muscle, and this is the iliococcygis. So this is pubococcygis, puborectalis, and iliococcygis, which forms the levator ani muscle. So iliococcygis, puborectalis, and pubococcygis. So this is the obturator internus muscle. For your identification, I've just marked it other colors. This is the piriformis muscle. So you can see this is the obturator internus muscle. So obturator internus muscle, and this is the piriformis. So this is the piriformis. The piriformis goes outside through the sciatic notch, and the sciatic nerve also travels anterior to this one. These are sacral nerve roots, which goes out through the sciatic foramen. This is the piriformis muscle. So this is the mesorectal fascia, and you can see that this is the mesorectal fascia. So it's pretty easy to identify, and once you know that this line, once you can identify this line, and it's very straightforward. And very few times you will have a difficulty where the mesorectal fascia is there. Lumbosacral plexus, again, this is the piriformis, and I think others are not required much. So this is the obturator canal, which you see, this is the pubis, this is the obturator canal. And like I said, sciatic nerve is formed by L4 to S3 nerve roots, descends anteriorly and above or within the piriformis muscle, and exits the pelvis through the greater sciatic foramen, and descends into the thigh between the adductor magnus and the gluteus maximus muscle. So this is the pudendal nerve. Again, this is the pudendal nerve. Not much required for this. Yeah, this is the sciatic nerve, which goes anteriorly. This is the level. So this is the sciatic nerve, which goes anterior to, this is the piriformis muscle on the sagittal view. So this is the piriformis, this is the piriformis, and this is the sciatic nerve. So the sciatic nerve goes anterior to the piriformis muscle. Piriformis arises from the F2, F3, S4 vertebra and exits the pelvis. So if you see a muscle which is going outside the pelvis, that is the piriformis, and this is the sciatic nerve. So the extent, the unresectability issues have changed. Previously, just reaching up to the sciatic foramen or the involvement of the piriformis would be deemed as unresectable. But now extension into the sciatic notch is considered as unresectable, or still there some resections or hemipelvectomy are being done resecting the sacral nerve roots. So the extent of surgery has increased. So the more you know, the more it will be better to see what all structures are involved and what all can be removed. Yeah, the same sciatic nerve. Sorry, slightly taking time to load. I hope this is not extensive. I mean, these are the basic anatomic landmarks which you have to see. So it's pretty easy. And then if you routinely see the MRI, normally there is a inhibition towards MRI because they feel that most of the residents feel that MRI is slightly difficult to read. But if you keep on looking at the cases, it's pretty easy. So this is the piriformis muscle. So this is the tumor, which is post-RT, it has become dark, hypo-intense. So now, as I said, like previously, the levator along the posterior aspect is involved by the tumor and fibrosis. So this is the levator on the sagittal view. This is the piriformis. So this is the coronal view. So this is the obturator internus muscle. This will be the mesorectal fascia, prostate femoral vesicle. So we haven't reached the rectum yet. So this is the rectum. And you can see this is a fibrous tumor, which is involving the sphincters laterally. This is the normal side and this is the abnormal side. And this is the tumor, which is involving the mesorectal fascia. And this is the sphincter. So obviously the plane of surgery would be beyond TMA. So extralevator abdominoperineal excision, that would be the plan. I mean, I am not a surgeon, but this is what my surgeon says. See, we are going beyond TMA. So the plane of surgery would be beyond extralevator APE. So here sphincters will be removed, but levator also is involved for extralevator APE. ELAPE is the surgery. So this is a tumor which is extending. So this is the mesorectal fascia, and the tumor is extending beyond the mesorectal fascia. So there is no way you will get a plane through the TMA, the mesorectal fascia excision. So the plane of surgery will extend beyond the TMA. So this is a tumor, and this is most probably a EMVE which is involving the mesorectal fascia. You can see this tumor is extending along the mesorectal fascia here and going beyond TMA. So here this is the levator, and this is the posterior portion part, and this is the levator, and which is involved. So again, role of MRI will detect early rectal cancers. Will undergo upfront surgery, and for locally advanced tumors, either NSCT-RT or long course RT or short course RT. So if at all, if it is a T3 tumor or T2 tumor, early T3 tumor, then patients can undergo upfront surgery. If the patient has more than 5 mm extension, ectopical extension to the mesorectal pad with nodal presence, then SCRT or LCRT is the treatment of choice. So why is like I said, the current approach is a preoperative approach. We decide on the patient selection for chemo-RT, radio chemotherapy, T4 or T3, and any N and CRM positive, and local excision, or then post-operative pathological assessment of the risk. So various surgical procedures, like I kept on saying, that abdominal anterior resection is for the upper and mid rectal tumors, low AR, abdominal perineal resection where the sphincters are involved, extra levator APR where the sphincters and the levator is involved, and intersphincter resection only the internal sphincter is involved, ISS is free, and exentration where the prostate, seminal vesicle, or posterior vaginal wall cervix is involved. So how high resolution MRI used in pre-treatment local staging? So if you see the mnemonic distance, and this is the mnemonic distance from the anal verge, that is what you have to see, whether it's a lower rectum, mid rectum, or upper rectum. T staging, whether T2 or T3, A for anal complex, N for nodal staging, C for circumferential resection margin, and D for extramural venous vascular invasion. So distance from anal verge, how is it mentioned? So this is the rectum, and where it reaches the skin, then that is the anal verge. So on distal section, you will see a hyperintense line. And on anal verge, this is the gluteal cleft. So when the gluteal cleft meets the anal canal, and where the anal canal becomes a circular part, that is the anal verge. And this is where you will measure from the distance from the anal verge. So you can see this is the, and the distance you have to measure is along the plane of the rectum. You will not draw a direct line from here till here. So when the rectum takes that curve, you have to measure this way and this way to identify the distance from the anal verge. So for low rectal tumors, the PR will most likely correlate with the MR finding. And for upper rectal tumors where PR is not possible, and the MR is the only way to identify the distance from the anal verge. So this is how you measure the distance from anal verge. And if it is located in the mid or upper rectum, you take it along the plane of the rectum. So again, T staging, like I said, involvement of the mucosa is mucosa submucosa is T1, muscularis propria it is T2, it is going beyond the muscularis propria it is T3, T3, and there are two classifications where 2, 3, A, B, C, and B, C, D are mentioned. So if it is more than 5 mm or less than 5 mm is what we report. If it is more than 5 mm and there is a node positive, then the patient has to undergo CT-RT. So like I said, this is T3, BCD, and T4B. T4B is involvement of adjacent factor, prostate. T4A is involvement of the peritoneal reflection. So T2. So as you can see, this is the muscularis propria, and you can see this is a polypoidal tumor just touching the muscularis propria, and it is not going into the adjacent fat. So this is a mesorectal fascia. So you can see this a line is maintained. So if at all, if you are very not sure whether the muscularis propria is involved or not, then it can be early T3. It behaves in a similar way to the T2. So if the patient doesn't have any node, then the patient can go undergo upfront surgery in this case. So this is another example of a small intermediate signal intensity tumor in the mid rectum. As you can see, this is the T2 tumor. So this is again early tumor where the black line is nicely maintained. So you might not always see this, but this is a polypoidal tumor. And if you have any doubt, you can always do a endoscopic ultrasound, and if it is confirmed that it is T2, then the patient can undergo upfront surgery. So this is a T3 stage where the tumor is extending beyond the muscularis propria. So you can see this is a beyond muscularis propria, and sometimes there will be a desmoplastic reaction which might mimic a extramural extension. So if there is a direct tumor budding, or you can see nodularity or the intermediate signal intensity, then you might call it as a T3. And if it is very thin spiculated lines, then it might be desmoplastic reaction. So this is another example of T3, where this black line, if you see anteriorly, it is maintained, and there is a breach along this aspect. So this is a T3 tumor. So this is above the puborectal extension. And this is a T4A tumor, which is involving the anterior peritoneal flexion. And prostate involvement, whether it is free. Like as you can see, this tumor, this is the black line of the muscularis propria, which is maintained. You can see a clear pathway. And anteriorly, this is infiltrating the prostate. And here, it is aborting the prostate. So if at all you are not sure, we'll just say this is aborting the prostate. This is a frank infiltration. So this is another example of pre and post treatment. So pre-treatment, you can see this is the black line of the rectum, which you can see the intermediate signal intensity tumor, which is infiltrating the prostate. And this patient has undergone CTRT, and this tumor has become mucinous, but the extent has not decreased. So the response, one of the responses of RT is mucinous change, and the prostate is still involved here. So this is another example of T4B tumor, where this is the urinary bladder and this is the upper rectal tumor, which is infiltrating the urinary bladder. You can see there is a luminal, intraluminal extension into the urinary bladder. And if the trigone is not involved, then the patient can undergo dome excision. And T1 also, in case of mucinous tumor, T1 will be useful. You can see there is almost looking like a normal fat, but on T1, this mucin will appear dark, and that is the tumor. So anal sphincters and puborectalis muscles. This is the mesorectum, like I said, this is the internal sphincter, puborectalis, and the levator, and this is the intersphincteric space. So this is a tumor which is involving only the internal sphincter. ISS is free. This is the sphincter involvement, and the ISS is effaced. This is involving the external sphincter also. This is a mucinous tumor involving the external sphincter. And see, this is almost reaching up to the outside of the external sphincter, and the levator is also involved. So another example where the ISS and the external sphincters are involved. See, this is the external sphincter, and that is involved. So if you draw a line here, that fat is lost here. That is the intermediate signal intensity tumor involving the external sphincter. So again, the nodal staging, like if you see multiple nodals, less than 3 it is N1, and 4 and more is N2. So these are the multiple mesorectal nodes. So this is the extra-mesorectal node, and this is the mesorectal fascia, and the node is sitting on the mesorectal fascia. So this is again nodes. This is a tumor, and this is the extra-mesorectal node, which is in front of the obturator muscle and lateral to the internal iliac, that is the obturator node. Again, this is the mesorectal nodes. And the nodes are also, if at all, if they are heterogeneous and irregular, then they are most likely metastatic. And circumferential resection margin, like I said, the potentially positive margin is defined as a tumor lying within 1 millimeter of the mesorectal fascia. So if the tumor or the node is sitting on the mesorectal fascia, it is the mesorectal fascia positive. And this is how we measure the distance from the mesorectal fascia. And if it is more than 2 mm, it is free. So here it is mesorectal fascia involved anteriorly. And what is extramural vascular invasion? This is the tumor which is extending into the adjacent vessel. So when there is a tumor with similar signal intensity and which is along the vessel, that is the extramural vascular invasion. Like you can see, it is taking the contour of the vessel. That is the extramural vascular invasion. So if EMVA is there, the chances of distant metastasis is also high. So the patient will, some places they are advocating TNT for these patients. So you should always look for a metastatic. A metastatic workup should be careful. So this is again another example of large extensive EMVI. This is going posteriorly, and this is a node along the vessel, or it could be a nodal deposit. So, like I said, rectal cancer T-stage must be assessed in plane strictly perpendicular to the long axis of the rectum. So, you have to advise your radiologist that we need the axis of the tumor, the plane should be axis perpendicular to the long axis of the rectum. And the depth of extramural spread is the key factor in determining prognosis. And the positive margin is defined as a tumor lying within 1 millimeter of reception. And positive margin can be due to deposits or tumor extension. So, like I said, these are all the features which decide the preoperative tumor radiation. Most importantly, T3 positive and sphincter complex involvement. So again, restaging for the rectal cancer. Now with the wait and watch protocol in use, the restaging should be very accurate. The sensitivity and specificity of restaging is very poor for MRI. But if there is no disease on MRI and on PR examination and on endoscopy, then the patient can go for wait and watch. And that is in low rectal tumors where their lesion is palpable. So again, evaluation of response on MRI. So edematous submucosa, it will be uniformly due to hyperintense masking the residual tumor. Dark hypointensity, that is because of the fibrosis. And then the mesorectal fascia can be thickened due to radiation RT. And it can be dark hypointense that could represent residual fibrosis with minimal tumor. So this is how the post-RT change looks like. So this is all fibrosis and this is all edema. You can see the tumor has become dark, fibrotic. So this is the disease and this is the post-RT change. And here it's fibrotic and almost completely resolved. So this is a PET scan and this is the tumor which is extensive fibrosis and which is lighting up on the PET scan. So this is again post-RT change with edema and which is showing uptick on PET scan. Again, TRG is to see how much of the tumor, residual tumor is present. Again, PET-MR, it's sparingly used. We have very few centers, but it might add value to the present MRI. So to conclude, high-resolution MRI is an investigation of choice for local issues, and non-fat suppressed T2-weighted MRI sequences in sagittal axis and coronal planes are mandatory. And MD chest, step-dominant pelvis for metastatic workup. So if you have to take home one message, that you ask for a small FOV, axial and sagittal coronal sequences, and no contrast is required. And these are the two articles which I have extensively used. You can go through these articles and they're very, very useful. You can keep it as a reference articles and refer to whenever you have in doubt. Thank you. And I think we have 10 minutes time for any questions.
That's a fantastic talk, Suman. You know, the importance of your name, Saklani, and the topic and the experience you bring shows in that we had almost 300 people who are logged in and listening, and Q&A and chat box is flooded with question and answer. It is not just from students. Lot of senior radiologists have logged in today. Lot of senior practicing radiologists, onco-radiologists, they have put a lot of questions. So beautiful talk. You know, looking at this, I feel you should start running routinely workshops along with you, Saklani, and the group. We should do a imaging one full day, proper workshop, train the trainers like that. Thank you very much. There are a lot of questions, Saklani, and you can open both the chat box, Q&A, and answer one of them, please.
Thank you, sir. And sir, just for information for all, there's a EPM workshop on MR rectal cancer, MR imaging rectal cancer on February 29th. I think
awesome.
Circulate that flyer.
Can you send the flyer to me? I will circulate it. And after this, you can just send to me in the WhatsApp. I'll circulate to everybody.
Yeah, Dr. Saklan is the organizing chairperson for that meeting. So I think he'll share it with you.
Fantastic.
Thanks, Suman. Great job, as always. So a lot of questions there. And I think 1 hour talk is not enough, and workshop is probably the right way people want to do it to the radiologist. I think one of the questions is from Siddharth, who says, should we take CRM and MRF margin as pre-neoadjuvant chemotherapy or post-NECT if initially it was involved?
Excellent question. That was, please, sir. Good.
I know. So I think the most important thing is when you see pre-surgically, MRF is mesorectal fascia involvement. So if you see on the scan, it is called mesorectal MRF involvement. Whereas after surgery, when the pathology sees it, then it will cause circumferential resection margin involvement. So normally you will treat as post-neoadjuvant chemotherapy because the whole idea of downstaging is to make sure the tumor shrinks down. But if you're going to operate the same thing, then a lot of people would have extended resection. So if the disease was going into prostate and it shrunk down to form TME, should you do an exentration? That would be an overkill. But there is no data actually comparing T4, which has been downstaged to T4. So we looked at study of it, and the local recurrences for these are not that bad. So we are normally, whole idea of downstaging is to decrease the extent of surgery or even wait and watch. So post-neoadjuvant chemotherapy, MRF involvement probably is better. So when you write an article, always remember MRF is mesorectal fascia for MRI, but on your pathology, you call it circumferential resection margin. Okay, Suman, another question for you. Can you clarify?
What I will do is, Saklani, lot of senior radiologists have joined. Some technical things, let him just answer Dino and then start. Dr. Dimpy, who is a very senior radiologist, has asked technical consideration. Suman, number one, MR rectum, contrast, no contrast, number one. If you have 1.5 Tesla, 3, does it matter? Suppose you have 1.5 Tesla, what would you do to enhance the capacity of image to read the proper rectal protocol MRI? So these technical things can you answer for the radiologist? Because what happens, everybody every time may not have 3 Tesla. Is it mandatory? Second, contrast, anytime required, not required. And then what are the technical consideration if you have a little lower MRI, how you can enhance the quality of this particular image and this. So if you can answer, all the radiologists are eagerly asking this, then Saklani will read out each question which is there on the chat box one after the other for you.
Yes, sir. The contrast or no contrast, then no contrast. So there have been various studies which have proven that the contrast does not add value. So it will only take more time, more resources, and patient discomfort. So without contrast, non-contrast sequences are sufficient. The contrast has not added much value to whatever we are seeing. And 1.5 or 3 Tesla, 1.5 Tesla is more than enough, and that is what we have been using in Tata. So, we have 1.5 Tesla machine, and no studies have proven that 3 Tesla has an added value over it. The only thing is it might be faster, but the chance of artifacts are more. So 1.5 Tesla is good enough, and that is more than enough. And to make it better, I think the only thing is you have to treat with the few parameters. And like I mentioned in the articles, they have been clearly given what all TRT should be employed. And small FOV is the go-for sequence for seeing the MRF and the local disease extent. So small FOV, coronal, sagittal and axial. These are the one sequences, and T2 large FOV to just look at the nodes for the at the level of common iliac nodes. I think these are the sequences that will be sufficient.
I think the contrast will increase the cost of the MRI also. With the other thing, they wanted to ask why no rectal coil as well.
So like I said, rectal coil is a painful, it's a large coil, and to insert it in rectum, it's a discomfort to the patient, and already the patient's rectal lumen would have been stenosed. So even if it is for early cancer, if it is a rectal coil is inserted, that might compress the rectal wall along the mesorectal fascia and gives a spurious involvement of mesorectal fascia. So rectal coil is not advocated. And endorectal gel can be used in very early tumors, and only very few centers have come up with this, and then it might add value, but routinely we don't use endorectal coil, endorectal gel also.
Okay, great. The other thing was discrepancy in length of rectum between colonoscopy and imaging. So I'll take that because colonoscopy can be anything else. The 5 centimeter can be outside the rectum. So imaging is good. But the most standard length is to have reduced sigmoidoscopy with fixed length one. Do you routinely use diffusion in rectal malignancy?
So So treatment naive tumors, diffusion will not add value, and in a post-RT setting, this diffusion might help us in deciding whether there is any residual tumor or not. So if diffusion is present, then this is not definitely tumor. It can be because of fibrosis also. But if diffusion is absent, then the negative predictive value is high. The chances that there is no tumor is high. So if diffusion is absent, T2 is normal, and it's completely fibrous, then I would call it as no residual tumor. But if diffusion is present, it can be equivocal.
So diffusion is mainly used for post, not for upfront one.
No.
I think Supreet has asked for upper rectal tumors. How can you what is clinically T3 and T4 in upper rectum versus lower rectum? Yeah.
If it is beyond the muscularis propria and involving the anterior peritoneal reflection anteriorly, then that is T4A. At the same posteriorly, if it is extending beyond the muscularis propria, then that will be T3. So posteriorly and laterally, there is a mesorectal fascia. So extramural extension at that level would be T3. Anteriorly, only if the peritoneal reflection is involved, then that would be T4A.
So for upper rectum, anterior peritoneal reflection is T4A. And
yes.
How do you measure Dr. Jagannath Dixit? Oh my God, he is also here as well. We've got big names here. How do you measure volume of mesoscale fat, which is important in android obese patients?
I think we don't measure the volume of the fat. Only surgeons would decide whether the patient, can undergo robotic or laparoscopic based on the assessment of the BMI. I don't think on MRI we would be able to assess the volume. We usually don't do that.
I know. I think the same thing you also asked about, is intertuberous distance any important? I think for surgery, I think for conversion and time for TME, I think there have been a lot of studies which have looked into that. So we haven't been routinely looking at this at all, but it has been done from Korea. So yeah, definitely there. Kiran Bagul has asked, how do you assess hypogastric nerves on MRI?
No, difficult. No, only we just say it's involving the prostatic angle, or it's going into the lateral aspect of the prostate, or the menovesical involvement is there, but hypogastric nerves we'll not be able to see it on MRI.
Okay, some basic question. Good. For liver and lung mets, why are we using CT instead of MRI?
So we have done a study in our center where the PET-CT has not added value. If the tumor is visible on PET-CT, that is clearly visible on CT scan. Where there is a resource crunch and the limited amount of slots for PET-CT, so CT is equally good to detect the metastasis. And any occult metastasis which are less than 1 centimeter will not be even picked up by PET-CT. So
they wanted to use MRI for liver and lung mets.
Like I said, MRI is cost intensive, time intensive, and then the availability of MRI is less. So CT is easily available, can be done in a very short span of time. And MRI is no added advantage over CT, except for that there is a radiation hazard. Other than that, I don't think MRI added any value.
Good. But there's a question of EMVI, how EMVI are seen on MRI. And in exam, can we comment on EMVI by looking at a single section of MRI, or do you require multiple sections? Then someone has asked how to differentiate between T3 and EMVI.
Yeah, EMVI, you have to look at multiple sections. Sometimes on one section, it might look like a nodular deposit, but in the other one, like you see it in a sagittal, you are not sure, then you look at coronal, then you look at axial. EMVI appears as a tubular structure which is in contiguity with the tumor, and the signal intensity of the tumor should be similar to that of whatever you see in the EMVI. And that vessel which you think is EMVI has to be expanded and nodular. And what else was the question? T3 and EMVI. So T3 is extramural extension, and if there is a very large EMVI which is in continuity with the tumor, that will be difficult. But if it is contained within the vessel, then it is easy to identify.
Okay, great. One of the most important thing, rectosigmoid tumor, should we do MRI?
MRI. So MRI, sometimes the rectosigmoid is below the sacral promontory. So if it is below the sacral promontory, and if you think that the surgical planning might change based on the MRI, then the MRI is required. So normally the patient gets a CT scan done, and then after seeing the CT, when the surgeon feels that maybe I require MRI, you want to see the posterior extent, whether the mesorectal fascia along the posteriorly or the sacral promontory is involved or not, then the MRI is required. So if it is below the sacral promontory, MRI would be required. If it is above the sacral promontory, then because of the bowel movement artifacts, MRI might not help much.
Okay, I think this is the rectosigmoid ones are the most difficult because MRI shows everything below and you can plan a surgery. Rectosigmoid can be unpredictable if it is bulky. So if in doubt, probably get an MRI. I think the last two questions, what is the slice thickness and FOB's field of view that you would use in TMH for rectal malignancy, and how to improve?
Yeah, slice thickness is 3 millimeters. That's for small FOV, and FOV is 20. And for large FOV, you can use 3 mm or 4 mm.
Right, and you say how to improve image, SNR, and resolution on 1.5 Tesla. Anything?
That I think you have to sit with your technologists and discuss. We can always improve it, and there's always scope for improvement on MRI. And as long as the radiologist sit with the technologist and say, I want a better quality, you'll always get a better quality.
Great. And Vishnu has asked in DWI, what is 600, 1200, 2400? What is referred to as, what is preferred to SSTRG?
So DWI, normally we take B0, B800, B1500. And see, this is the in comparison with Earth's magnetic field. So higher the B value, then the artifacts will be less, and then the tumor will shine through. And for ADC comparison, to calculate the ADC values, also B value is used. And next question was, sir?
What is the preferred thing to assess TRG?
TRG, normally MR TRG, we are comparing with the pathological TRG. But the Mandat scoring, like I said, it only compares the amount of fibrosis compared with the amount of the tumor. So we always, if at all, if we have to see the similar one, we should not compare it with the previous MRI. The present MRI, how much is the content of the fibrosis and how much is the amount of the tumor, then we can give them the TRG scoring. So MR TRG score always does not correlate with the pathological TRG. So TRG is only just to see how effective the treatment was and what is the biology of the tumor.
Right. I think Kiran Bagul has asked, what is the best imaging for anal canal?
Again, MRI, sir. MRI is the best modality to see the sphincters, intersphincteric space, and any levator involvement.
Sure. I think Meda has asked, do you consider ISRS for patients with, maybe ISR for patients with intersphincteric plane involvement pre-CTRT and resolved on post-RT? So, because that MRI has 50% accuracy. Actually, Meda, there is no actual data to say if the intersphincteric plane was involved before and it has got downstage after CTRT. Can you do intersphincteric resection? Yes, technically you can. Fibrosis is there, but local recurrence can be slightly higher. So, but there is no data which is compared just before or after. But normally, if you do intersphincteric resection, you want your local recurrence to be less than 5%. But if you do this, then your local recurrence is likely to be higher, but data isn't there. So that is good. I think thanks, Suman. That's been a great thing. I'm sure everyone loved it. And I think we are going past time. We have to thank Somashekar for arranging this. And I'm sure a lot of people would have benefited from him. You can do only good surgery, okay, when you have a road map, okay. You can have only a good building, but if you have a good architect. So the radiologists are the silent architect for our beautiful mansions that we build. Thank you very much, and we hope to see you next time.
Thank
you, Suman. Thank you, Saklani. Fantastic coordination. With the questions pouring in, you can see, Suman and Saklani, how important this topic is and how everybody is really dying to get more knowledge. This actually tells us we must all register to Saklani and your course and attend. Heartfelt thanks. As I always say, the whole thing about teacher is not to spoon feed, to show a direction, stimulate the brain. The student has to walk the path and read the articles which you quoted in your last slide. and then they have to find their own path. Thank you very much. We can't give anything to you because, for somebody who has knowledge of well and such a good nature, all of you, only thing we can give on behalf of DNB board is a blessing for you and your family from students, board, and me. Thank you very much for this hard work. Thanks, Saklani, and thanks both of you. Excellent talk. Over to you, Navneet Singh.
Thank you.
Yeah, thank you very much, trainees and faculty members, for joining the session.